Hello everyone and welcome back to the channel. In this video, we will be looking at the fascinating and evolving branch of psychoradiology. So first, we will look at some of the common imaging modalities that are used in neuropsychiatry. Then we will look at the future prospects of neuroimaging in psychiatry, where the field is heading to. In this session, we will be discussing three major domains of neuroimaging. The first will be anatomical imaging, followed by the functional imaging, and the last one will be metabolic imaging. And we will also discuss how these will help us in evaluating common neurodegenerative conditions as well as major psychiatric disorders. Before the advent of the modern neuroimaging techniques like CT and MRI, the clinicians had to depend totally on detailed history taking as well as detailed neurological examination. About half a century ago, the introduction of the computed tomography marked a revolutionary turning point in medicine. For the first time, we were able to visualize the intracranial structures in a non-invasive way. And from this point of time, the detection of tumors, hemorrhages, as well as structural abnormalities became easy. Today, neuroimaging is no longer limited to identifying gross structural abnormalities. Rather, we can identify the brain connectivity, the functional activation patterns, neurochemical changes, subtle microstructural alterations. And this advancement have opened new dimensions in understanding neurodegenerative conditions as well as psychiatric disorders. So we can divide the neuroimaging modalities used in neuropsychiatry into two. The first will be the anatomical imaging, which comprises of the computed tomography or the CT scan, which is used to detect hemorrhages in acute settings, and the MRI or the magnetic resonance imaging, which will give us a superior soft tissue resolution. Functional imaging, in contrast, focuses on the dynamic processes that occurs inside the brain. So instead of just focusing on the structural abnormalities, it focuses on how the brain is working. As I said, psychoradiology is a non-invasive method to identify the structural as well as the functional changes in the brain of patients with psychiatric disorders as well as the neurodegenerative disorders. One of the most important contributions of functional imaging is that we are able to identify illness-specific alterations. For example, in patients with major depressive disorder, there are multiple studies pointing towards reduced hippocampal volume, which occurs secondary to chronic stress exposure, elevated cortisol levels, as well as reduced neuroplasticity. In schizophrenia, functional imaging shows hypoactivity in prefrontal cortex, which is the area of executive functioning as well as decision making. So this can be attributed to the negative symptoms as well as the cognitive deficits in patients of schizophrenia. Functional imaging in patients with post-traumatic stress disorder as well as generalized anxiety disorder consistently shows hyperactivity in the amygdala. Amygdala is a region which plays a central role in fear processing as well as threat detection. This explains the heightened emotional reactivity as well as the exaggerated fear responses in patients with PTSD as well as generalized anxiety disorder. Based on Bayer et al.'s study, there are a certain red flag sign which indicates imaging in psychiatric disorders, which are neurological signs or symptoms, pre-existing neurological condition or brain pathology, significant change in presentation, family history of neurological disorders, history of head injury, seizures, acute onset of delirium, or prior to electroconvulsive therapy. Now let's move on to the magnetic resonance spectroscopy or the MRS. Unlike the conventional MRI, which helps us to identify the structural changes in the brain, the MRS helps us to identify the biochemical changes that occurs in specific locations of the brain. In other words, it helps in quantification of specific metabolites in specific regions of the brain. These metabolites have standardized values. Any deviation from these standardized values point towards pathology. Now let's see some of these important metabolites. The first one will be NAA or the N-acetyl aspartate. N-acetyl aspartate is considered as a neuronal marker. It represents the neuronal density as well as the neuronal viability. So when there is a neuronal loss or degeneration in neurodegenerative diseases or severe brain injury, the levels of NAA goes down. Then we have choline. Choline is a marker of the cell membrane turnover. So in conditions like glioma, where there is increased turnover of the cell membrane, the levels of choline goes up. Lipids and lactates are other important metabolites. Both will go up when there is tissue damage or hypoxia. And the last one will be MI, which is the myoinositol. This goes high in Alzheimer's disease. Next, we will move to the ASL sequence or the arterial spin labeling. What exactly happens in this? In this, the arterial protons are used as an endogenous tracer to measure the CBF or the cerebral blood flow. So, after doing this arterial spin labeling, we will be able to identify certain hyperperfused areas as well as the hypoperfused areas. So, in certain tumors which are highly vascular or high-grade tumors, there will be increased perfusion due to high metabolism. And in various dementias, there will be reduced CBF or the cerebral blood flow in frontal, temporal as well as the parietal lobes. Initially, the blood in the carotids and the vertebral arteries will be tagged and we will do an imaging. Later, this tagging is removed and then an imaging is repeated. Then the tagged image is subtracted from the controlled image, which will give us the CBF or the cerebral blood flow. The next one will be the diffusion tensor imaging or the DTI. So before explaining this, we have to know two terminologies, which is isotropy and anisotropy. Firstly, isotrophic diffusion. Isotrophic diffusion means that the molecules move equally in all directions. In anisotrophic diffusion, the movement is directionally restricted. So in brain, this occurs primarily in the white matter tracts. Because axons are arranged in parallel bundles and are surrounded by myelin, water molecules tend to diffuse more easily along the length of the fiber rather than across it. So in simple terms, isotrophic diffusion is equal in all directions, anisotrophic diffusion is directionally dependent. So what does that mean? What if the white matter tracts shows isotrophic diffusion? If it shows isotrophic diffusion, it is abnormal. So it can point towards a tumor or an infarct. The next question is this diffusion measurable? Yes, it is. There is something called as the FA value or the fractional anisotropy value. So this ranges from 0 to 1. 0 is abnormal and 1 is towards the normal side. So there is something called as normogram, which already have standardized values of this FA in all the regions of the brain. And when we compare these FA values with patients of psychiatric disorders, for example, ADS patients, alcohol dependent syndrome patients, showed lower FA values in the genome of the corpus callosum when compared to the standardized FA values. In patients of schizophrenia, showed lower FA values in the whole white matter skeleton when compared to the normal or the standardized values of the FA. The next one will be fMRI or the functional MRI. So in this, when the patient is inside the scanner, the patient will be asked to do a specific task. Could be a motor task like finger tapping, could be a visual or sensory stimulation, or could be a language task as well. So this works on a principle called as BOLD, the blood oxygen level dependent contrast. It measures the differences between the oxygenated and the deoxygenated hemoglobin, which indirectly point towards a neuronal firing or activation. So when the patient is given a motor task, there will be activation of the motor cortex. When the patient is given a language task, there will be activation in both Wernicke's and Broca's areas. When the patient is given a visual stimulus, there will be activation of the occipital cortex. When the patient is given a sensory stimulus, there will be activation of the somatosensory cortex. If there is any hypoactivation or hyperactivation of a particular region, so this can point towards pathology. So this is very relevant in neurodegenerative conditions as well as psychiatric. Then there is resting fMRI. So this is done when the patient is not doing any activity, but the patient is awake. So the brain's DMN or the default mode network is active during the resting fMRI in normograms. So in patients who are having psychiatric disorders, especially schizophrenia, these patients have a disrupted DMN activity in resting fMRI. Now let's see PET and SPECT. PET is positron emission tomography. So the relevance of psychiatric disorders lies here. In patients who are having psychiatric disorders, there will be altered metabolism in different cerebral regions. So in major depressive disorders, there will be hypometabolism in the dorsolateral prefrontal cortex, and in some cases there is hypermetabolism in limbic structures. So this actually correlates with the anxious ruminations and emotional dysregulation. In schizophrenia, the PET studies shows hypometabolism in the frontal cortex. So this is referred to as the hypofrontality. So this can be correlated with the negative symptoms as well as the cognitive deficits in schizophrenia patients. In patients with obsessive compulsive disorders, there is hypermetabolism in the regions involving the cortico-striato-thalamo-cortical circuit. Now let's move on to dementias. In dementias, there is a preclinical stage where there are no obvious clinical symptoms, but there are pathological changes, followed by a stage called as MCI or the mild cognitive impairment. So during this stage, there are cognitive symptoms as well as the pathological changes, but the patient will be functioning independently and the activities of daily living are not affected in this stage, which is followed by a major cognitive decline, what we clinically call dementia. In this stage, the patient needs help. So the patient won't be able to function independently and the activities of daily living are impaired in this stage. Now let's see what happens in Alzheimer's disease. So in Alzheimer's disease, we can see changes in ASL sequence, MR spectroscopy, as well as the structural MRI. So first, let's see what happens in the ASL sequence. So in ASL sequence, there will be hypoperfusion of the posterior cingulate cortex as well as the parieto-temporal regions. On MR spectroscopy, there will be increase in MI, which is the myoinositol, and there will be reduction in NAA, which is the N-acetyl aspartate. And on structural MRI, there will be volume reduction in hippocampus as well as the global brain volume. Now let's see what happens exactly in Lewy body dementia. So in Lewy body dementia, the primary pathology is the deposition of alpha-synuclein inclusions in brainstem, in the neocortex, in the limbic cortex, as well as the substantia nigra. So on PET scan, there will be hypometabolism in the occipital cortex, and on the susceptibility MRI, there is some specific finding called as the loss of the swallowtail sign. So this is actually indicative towards either Lewy body dementia, or sometimes it is seen in Parkinson's disease as well. Now let's move on to FTD, or the frontotemporal dementia. This is usually autosomal dominant and has two main variants. The first one will be the behavioral variant, and the second one will be the language variant. In behavioral variant, there is frontal lobe atrophy as well as the anterior temporal lobe atrophy. Language variant of the FTD, there are two further subtypes. It will be non-fluent and the semantic type. So in the non-fluent type of FTD, there will be atrophy in the left posterior frontal as well as the insular regions. And in the semantic type of the FTD, there will be atrophy in the anterior temporal lobe as well. What happens in vascular dementia? In vascular dementia, the MRI shows white matter hyperintensities, which are graded on the Faseca scale from 0 to 3. And along with this, if you do an MR spectroscopy, so you'll be able to find the reduced NAA levels. So NAA is the N-acetyl aspartate levels. But the levels of the myoinositol or the MI levels will not be having any significant change as it was there in the Alzheimer's disease. By combining structural studies, functional connectivity, the perfusion studies, as well as the metabolic markers, we move closer to precision psychiatry, where the diagnosis is not only made by the symptoms, but as well as objective neural signatures.